We're live. This is the first MI Live I think we've done in a couple weeks. As you can tell, it's just me, no Jay today because I did not do the fancy intro. And I do have with us our all-star guest, Dr. Mike Stair. Mike is a fellowship-trained physical therapist. He is he owns Spectrum Fitness Consulting. And how many practices do you have on the East Coast?
We have two physical therapy practices and 2 fitness studios.
Nice. And normally you're globetrotting all over the world, but this year you're probably at home more often.
Yeah. It's the first time in 11 years I've gone more than a month without being on a plane. So
isn't that crazy?
It is. It's weird. I'm getting my itinerary, requests sent in. Supposed to be going back to Florida in January, but we'll see how that goes.
I know. I don't love traveling. Like I don't hate it, but I don't love it. The one trip I was looking forward to this year is we were supposed to go to London. So I was supposed to go give a couple talks, and then we were going to stop in Dubai on the way back for the Formula One race, but that got scrubbed. So that was a little sad. But other than that, it's been kind of nice to be home a little more than usual.
Yeah, I get that. I think it's like at least 36 days a week or a year I'm gone. So yeah, it's nice to be. It is good to be home more.
So cool. We have some interesting topics to jump into today. I think we'll start with maybe kind of the broader topic. And this is, we talked about this about a week or two ago. What are the most important questions you need to have answered prior to seeking help for pain or injury?
Yeah, this is something that I wish everyone that was going to see, whether it's a physical therapist, a chiropractor, a doctor, or even a trainer, because having these questions at least thought through, it's going to enable whoever you seek to get help from to be far more effective. A lot of times people just show up and they think, that there's going to be a special test or maneuver or imaging study that's going to reveal all the answers. But if you come prepared and having thought through some of these questions, and even if you don't have clear answers, at least thinking about it. So the number one question that I think is most helpful, not only for you to ponder, but again, for a clinician to help you, is what reproduces your pain? And being really specific, what specific times a day, what activities, what positions, what movements. And most people gravitate to some obvious things like lifting or pushing or exertional things, but more often than not, I find it's somewhat what people deem more innocuous activities, like sitting at their computer or how they're doing some day-to-day tasks. So I think that's the number one question, and also like what activity is it? Don't rule out things like the position that you read in, or what your ergonomics are at work, or the fact that you notice that your pain's worse on the weekend as opposed to during the week. So that's the number one.
So one quick question on that is, so when you're kind of trying to describe what reproduces your pain, I think, how many of your clients do you think have trouble describing it in a way that's like relatable to you as the practitioner, right? I think, on the practitioner side, we think of like, hey, is it chronic or acute? Is it localized or diffuse? Is it stinging or burning? Is it an aching? And how many of your clients struggle with kind of really pinning that down?
I think a lot of people struggle with it because they believe that if they're not particular about talking about the nature, as what you're just describing, is it burning or is it tingling or is it fuzzy, or is it achy, or is it boring or deep? Those descriptions, they're important to the person, but from a clinical standpoint, they're not very helpful. So I try to get people away from focusing on the stress of having perfect descriptors. Putting words to pain is kind of like saying what yellow tastes like.
Yeah.
It's a very stressful thing. And I think the biggest stress is people think that if they're not good at describing it, the clinician's not going to be able to help them. So I try to relieve them of that, saying like, listen, your description, how you describe it, is probably less important of all the questions. I'd say there's probably about 7 questions. And although it usually comes up that they describe it. And sometimes I ask for more clarifying things. It's not in my top 5 or type 7, questions that I ask people.
Okay. So, after that first question is kind of describing what reproduces it, what are the next things that you should give some thought to?
The next one is the onset of it. Did it happen suddenly, or was it gradual over time? Could you depict a specific time or incident, or do you have no idea? Clinicians call that insidious onset. That does help us get a little bit deeper to the variable that might be provoking or correlating with the onset of your problem. A trauma is the easiest one. I went to go pick up something and I felt a pop in my elbow, and I noticed this weird deformation on my arm. Whereas my shoulder's been aching a little bit. I noticed it sometimes when I was lifting a little bit heavier a few months ago, but I can't really pinpoint a specific movement. That's fine too. That just tells me what amount of investigation we need to start doing, what type of exploration we need to do. So that's probably the second most common one. Location is an important one. So although when people say, I feel it right here, what is that? No good clinician can tell you that. It could be a whole bunch of things. But there are some patterns. For example, if somebody is coming in with shoulder pain, and they start feeling pain that goes down below their elbow into their hand, or it radiates up into their neck, although not super sensitive and specific for delineating a cervical problem, it does tend to correlate. It at least gets me thinking, I need to ask more questions about neck issues, because that might be provoking some of the symptoms that might be masquerading as a shoulder problem. So location, again, isn't so vital diagnostically in terms of specifying it's a tendon or a ligament or a joint issue, but it is good in regionalizing things. Is this really a foot problem, or is it perhaps being referred from the back? Those aren't completely uncommon issues that we have to not think about. So I'd say, so we have what reproduces it, the onset, location. You brought it up a little bit too. I like to find out about the intensity, the duration, and the frequency. Is this episodic? It comes and goes. When it does come on, is it just intense and goes away quickly, or is it, does it linger on for a long period of time? Sometimes I do like to, although I think there's too much emphasis on this, I do like to quantify it in their own words. You've heard the 0 to 10 out of, scale. I tell people if it's 10, we're getting on the phone and getting you to the ER right now.
Yeah.
You're not talking to me right now.
I think the 1 to 10 scale is maybe the most useless scale in all of medicine. It's like everybody has a 10.
Well, yeah, but to me, I find it quite valuable because there are people that have different dispositions about pain. Some people are very stoic about it, I haven't been sleeping and I can't go to work, it's like a 3. Yeah. Other people are like, it's a 10. I'm like, really? I was like, are you able to function? I mean, are you, vomiting? Are you able to eat? Can you sleep? Like, oh yeah, I sleep fine. I'm eating fine, and I'm like, well, does it hurt you right now? Well, no, it doesn't hurt me now, but normally it's a 10. So it is helpful though, because some people are a little bit more sensitive and that's a bigger priority. Other people, they deal with it differently. So that's usually what I'm trying to do. I'm not trying to say, oh, this person needs surgery because it's an 8 out of 10. Conversely, I'm not minimizing, it's only a 2. What are you doing here? But I think the last 3 questions are the ones that are least common and are very helpful. Have you had this before? And if so, what helped and what didn't help? Having some clues about, well, sometimes people don't think about it until I ask them this. And like, actually, yeah, I did have this a couple years ago. And I remember, I just worked through it, and surprisingly, it was worse when I started, and then later it kind of felt a little bit better. Other people are like, yeah, I did this, and the only thing that got it better was manipulation and rest or so. Because if you're thinking what's going to get this better, to load that Achilles is, 3 sets of 10 towards a 6 out of 10 pain scale with a level of load that you couldn't do more than 10 times. And they're thinking, I need Graston technique. You got to you can't just jump in with what your treatment is if they're completely on the other end. You have to kind of massage it in, no pun intended. But so that's one. But my favorite one to ask is, what do you think is going on?
Yeah.
Getting their perspective, they might be taken back by that, but that's kind of related to my prior point, which is you need to see where they're at in terms of, are they expecting and hoping for passive treatment? Are they thinking or hoping that they can just bowl through this and work this out with aggressive massage and heavy loading? Because you have to get a therapeutic alliance in order to get somebody better. And you have to be close. And if you know that you're at the opposite end of where they think they should be, you have to, work your way so that you're on some common ground. You might have some more education required. If you're both aligned with the same thought, like, I think there's something I did that aggravated it while I was lifting, and I think I need to be smarter about, lifting first thing in the morning and warming up better. So, and you're on the same, mindset, I think that helps. And my favorite one, this is my favorite question after I ask all the other ones. What do you think is a good outcome? What would you feel is, or what do you want to happen from, seeing me or seeing a clinician, or from getting rid of this problem? What does that look like to you? You'll be very surprised as somebody asking it of somebody who's looking to you for a solution for pain, there's diabolically different, responses people are looking for. Some people are like, I just want to get a couple ski seasons left out of this knee. Other people like, I need to get rid of this pain tomorrow because I got a wedding to go to and I'm not going to be, in a bad mood because of this. Others like, I don't care about the pain. I just want to be able to throw as fast as I was, for the, playoffs coming up. Mm-hmm. So that's really important, because then it's like an investor. If you go to an investor and you say, I really need some advice about investing, and you find out that, they have all their money tucked away in a mattress, and they're absolutely, floored by the idea that they might lose a few $100, you're going to be a lot more conservative in your advice, in your strategy. Conversely, if they're like, hey, I just want, 40 years to have a decent amount of money so I can take some risk, you're going to be a little bit more aggressive with that. So I think that is probably one of the most effective questions to find out and have an answer to if you're the patient. It's also a good way, I think, to evaluate your help.
Yeah.
If these people aren't asking your perspectives in these questions and they just flop you on a table and start moving you around, I haven't found any clinician, even anecdotes of somebody that can help somebody very well by doing that. So yeah, those are my main ones, my top 7.
And how much of that do you feel like should be kind of practitioner driven? Like you should be asking those questions versus the, priming the patient to try to think through those things. Because I think, from my perspective, whenever I've gone in to physical therapy, is I just show up and I'm like, hey, you guys should be able to solve my problem. Like how much forethought have I actually given? And I don't know if I have a good answer for that from the patient perspective.
Yeah, I find the best outcomes when it's both parties. The best scenarios, I do local seminars to the general public for free. They come to them and I give them all this information. Those patients that come in to see me after that as actual patients, they're the easiest patients to work with because they have already thought through the scenarios and went through. They know that, for the shoulder, that impingement isn't exactly what they were told on, WebMD or so for the shoulder. They know to start looking for, hey, when I do reach behind my back and when I sleep on my shoulder, that's what's making it worse. They know to come in with those descriptions. That being said, I think the ultimate responsibility is on the clinician. I mean, that's our job. You're coming to us for advice. So the clinician should be priming you for these questions. I have to say, though, that there are some clinicians that are a little bit warped on to what they think their role is. So many people do believe that, like, well, listen, you're coming to see me for me to fix you. So you're not here to get a 30-minute discussion about pain and ergonomics. So I'm going to put you right on the table and start moving you and start doing some things. So it's feeding into the expectations. You see a chiropractor, and I know chiropractors who have very similar treatment approaches that I do, and their patients are disappointed that they hadn't got manipulated and moved on their first session. Surgeons tell me this all the time. They said, I'm good because I'm a surgeon. I'm not a good therapist. I'm not a good movement guy. But I'm the one that decides if I'm going to cut you open or not. So why are you asking me all these nuanced details? That's what physical therapy can do. So some of them look at their roles as kind of defined by patient expectations. I think it should be mostly the role of the good clinician to ask these questions, but I think that's much easier if the patient expects to have these answers or shares that information.
Sweet. Before we dive into the next question, I do have a question from a listener, actually one of our coaches, and I can't read all of it, but I'll try to read what I can. So Hannah said she was in a car accident about 1.5 years ago, and now things seem to be getting worse, not better. I'm still going to physio and massage therapy. The only time I really seem to get any relief is after decompression. My left leg is completely numb with the exception of a pretty constant ache through my outer quad, IT band, and TFL. I get a shooting pain through my popliteus at the end of the day and into my calf now. I've dropped compounds doing core works, staying mobile. I stretch, and she's probably just kind of giving us more of her exercise modalities, but I think that cut it off. But yeah.
Well, Hannah, it's a great description in relatively a short amount of information or time, and also I appreciate the question too, because I think a lot of people have that issue. So the decompression that you're talking about, when people have what is suspected to be some type of nerve issue, maybe a radiculopathy, and again, it would take a little bit more information for me to be able to determine if that's the case. It is very, very commonly something that people get relief from. I've had 2 severe spine injuries, one at the neck, one at the back, and I too, that was the major relief I got was always from that. So what I try to teach people to do with the decompression or traction is what some people call that. You can do that on your own. There are self mobilization or self-traction strategies you can use. Do those frequently. Do those for short duration. So intermittent traction tends to work much, much better. The constructability, the evidence behind it in terms of an intervention isn't great. And one of the reasons why is because, like any spine issue, there's almost never one treatment that will work. It's usually a series of things in combination for especially people with pain that refers down their limbs. It has been shown to be quite effective. One of the reasons might be desensitizing, the nerve. Another reason could be improved nutrition to the tissue, which has been proven to occur at the discs. Regardless, it is a low risk and high effective strategy, and it can be done. And that's the problem with it, though, is that people come in and they get great relief when they're on the table, and then they go out and do their day-to-day life, and it worked. It's 2 steps forward, 2 steps back. So my job, I find, is to show people how to do that on their own and reproduce it in the clinic and show them how they can do a similar type of thing and do it frequently. I even have had, and I did this myself, in my mind, it seemed like, well, if I do compound lifts and if I do heavy loading, that will aggravate my leg. And if I do traction, it makes it feel better. So thus, I'm not going to do compound heavy lifts or loading. I didn't find that to play out very well with many patients for myself. So what I realized, it wasn't the magnitude of load that was a problem. It was the chronicity of the load, the duration of the load. So people who have had instability after a car accident or have had some type of spine damage, I have found that they can get back to doing, and in fact, they should get back to doing relatively high load or high difficulty exercise, but do so intermittently. And then when they do traction and decompression, do that intermittently throughout the day. So for example, right here, when I'm talking, you might notice that sometimes, Brad, as we're talking, I often will, push down in my chair, do that. That's just a very casual form of deloading. A more aggressive form would be hanging from a chin-up bar or a lat pull-down with heavy weight. So I'm trying to think of a resource I can give you on that. I'll think it through and maybe chime in, because I know you're active on the as a coach in the macros community, and send you some info on that. But in short, what I would tell you, stick with the decompression stuff. Try to find some self decompression options. Don't always assume that just because you're sensitive to load that you can't get back to loading, as long as it's done intermittently, gradually, as opposed to chronically. So I hope that makes sense. As far as the other issues, be wary about stretching as a means of decreasing symptoms. Oftentimes, people that have had some type of trauma from, again, a car accident, there is some hypermobility, and it might feel stiff. So therefore, you try to stretch it. But what might unwittingly be happening is that you might be actually stretching ligaments or stretching nerve tissue, which I use the analogy like having a wound. It's healing, it gets itchy, you rub it, you scratch it, it temporarily feels better, but you might be aggravating the histamine response to make it itchy or scratchy later on. So again, without knowing a little bit more about your presentation, into more specifics, but in general, I have found when people pump the brakes on trying to stretch out like that tight popliteus, then sometimes their symptoms actually improve by not stretching it as much.
That's interesting, because I would say it wasn't a car accident, and I don't think it was from back problems, but I had very high, pretty bad pain in kind of the same areas, popliteal problems. And when I stopped stretching it and just kind of stopped rehabbing it, it actually got better, which was interesting.
Yeah, the most common treatment that I have found that works in people with sciatica or posterior calf, posterior thigh pain that it's suspected to come from a nerve origin is, the first thing I tell them to do is, for 2 weeks, don't do any calf stretches, don't do any hamstring stretches. And I'd say 80% of the time, there's a significant reduction in pain. I'm not saying that stretching is bad by any means. Just when you have an irritated nerve, it's nearly impossible to isolate the muscle to stretch and not concurrently overstretch a much more sensitive dural or nerve tissue. So sometimes that tissue just needs some time to calm down, and it's the opposite of how you treat a tight muscle.
Perfect. Should we move on to the next topic?
Yeah, sure.
This is one I'm interested in, just because there's a lot of stuff I don't know the answers to. So I'm hopefully you have more insights. So rehab modalities and gadgets, do they really work? And we have a list of them, and I guess we can just kind of bounce through the list.
Yeah.
The first one we have on here is ultrasound.
Right. So ultrasound, two mechanisms that's theorized to be able to work, both of which have proven to be not true. The one that has some evidence on it, and ultrasound, the idea is that you're going to send through ultrasonic waves. It's going to cause the particles in its field of influence to resonate more, generate heat. They have shown that you can raise the temperature of the skin about 1 centimeter below the sound head, and in an area about I think it's like 1.5 times the size of the sound head. You would have to be able to, in order to get the tissue 1 centimeter below, to increase temperature by 1 degree Celsius, you'd have to focus on an area 1.5 times the size of the sound head for 8 to 10 minutes. So just a simple calculus here, you are spending a lot of therapy time just to try to get a tissue that is incredibly superficial 1 degree warmer. And if that's the mechanism of the effect, I can get tissues far deeper, warmer just by moving them in about 2 minutes.
Yeah.
So if that's the proposed effect, looking at the outcome studies are just, I mean, it's not really debatable at this juncture. It's hard to get really good studies in this stuff, but that's pretty much a shut case.
So why is it still used? Like every time I go into a PT clinic, there's at least one person there getting ultrasounded. And I remember when I worked in a PT clinic as an aide, I would give people ultrasounds.
Yeah, I get, unfortunately, some, I think, bad theories as to why. You can code it very easily. It's not questioned. It's easy on the clinician. It aligns with expectations for passive treatment. Those are unfortunately the reason. I'll tell you a very funny story about this, and I will do my best not to implicate the person involved in the story.
You can throw my name under the bus if you need to.
No. This is a great clinician I had a chance to work with, and I'll leave that there. But the person was being hounded by the patient, saying that it's on the script. My doctor says I need ultrasound, which they forget that this is a check mark that they have been checking for the last 3 decades without any thought. It's probably already pre-checked on their prescription. So everyone shows up with a, bike, ultrasound modalities, Therex. So thinking that this was some critical component of it, wisely, the clinician said, okay, you know what? You've made, your thoughts known very well on this. Let's give it a try for, at least a couple sessions and see how it goes. And I witnessed the clinician do this. So clinician is giving the patient ultrasound. After about 8 minutes of the ultrasound, the gel's being wiped off, going through the whole charade of everything. And, the cart's getting wielded over. How you feeling? She goes, oh my God, I am so much better. Thank you for finally listening to the doctor on this. I mean, this is exactly what I needed. And she goes, well, that's interesting because I don't even have it plugged in. So the look on that patient's face, and I'm like, that's some serious, what, to be able to do that. But I couldn't believe they did that. It was quite effective. I mean, the patient finally started to listen to them and, understood the notion of placebo. But so I think there's a lot of reasons, unfortunately, they're not very good reasons.
That's pretty comical. That sounds like something I would have done.
Yeah, I mean, I that person's like, I was floored. I was like, it's like one of those things, like it's like watching somebody do a trick shot, when they're playing pickup ball, and then to do it in the middle of a game, that was pretty bold. I thought that was pretty impressive.
So ultrasound's a hard negative. What about e-stim?
So e-stim's pretty interesting. There is a researcher, I think it's Lynn Schneider-Mackler, and Delaware, and she had done some decent research showing that it can be effective post-operatively. In those very early phases where some people, I don't know if you've ever had a knee surgery, Brad, or anyone listening, but sometimes for some people after they have a surgery, just their brain and their muscle just completely goes offline. Yeah. They have no idea what it feels like to get a quad contraction, especially the quads after a knee replacement or ACL. And they have found that there's quicker improvements in strength gains in people that did e-stim. There's 2 basic types of e-stim. One is what they call Russian stim, which is a much higher level of stimulation to the extent that it actually causes the muscle to involuntarily contract. I found it also be good for biofeedback, so people can get the feeling of what it's like to contract the muscle again. In all scenarios, I prefer to get their brain to do it if they can. But the evidence is hard to ignore. Whether it's clinically significant, depending on statistics, it's hard to debate whether it is or not. But at least it's not a waste of time, and it might not be a bad adjunct. So the other use for e-stim is for pain modulation. It's going to the old school gate theory pain that most of us learned about. It's like when you bump your elbow and you rub it. The the ascending fibers that go to your brain, the sensory ones that, do sensation, light touch, tend to travel faster than the nociceptive ones. And that tends to, it's that competing stimulus can kind of drown out the pain signal and might make the pain intensity less. There's decent evidence on that as well. The problem is that it is only effective for the duration in which it's being applied. So if you have an 8 out of 10 chronic pain and you have E-stim on it, it might bring it down to a 6. And that's not insignificant for somebody that's in a lot of pain. The problem is that once it's taken off and you go back to your car and go on with your life, it doesn't last. So what I will do for patients that have chronic pain and are, in addition to other strategies, need some, even if it's minor pain relief, I will test it out once in the clinic. And if there is a significant reduction in their perception of pain, then I will call a vendor and I will try to get them a home TENS unit. And that's a type of E-stim that can be used for sensory on pain modulation. And most insurances will cover that. I don't occupy any of their treatment time with that. If they're there to see me, there's a lot more skilled and effective things I could be doing than, putting them on a pad and go doing some notes. Yeah. So, and again, if it's going to work, it makes sense that they would have it at their disposal, all throughout the day, as opposed to only a couple times when they come into the clinic.
Have you ever tested one of those on yourselves and just turned it all the way up to see what it felt like?
Oh yeah. Oh, of course.
It's pretty intense.
Yeah, it is. I actually had one when after my patella tendon rupture. I used it for early stim, days after my surgery. And of course I decided I was bored and nothing else to do. So I'm getting my, extensor helix longus to fully contract maximally at my foot. And
yeah, we used to mess around with those and be like, see who could handle the highest, the longest. And yeah. So TENS units, we kind of covered TENS units as well. The next one is Graston /AISTM.
Yeah, instrument assisted soft tissue mobilization.
Okay.
Graston is, it's the tendency to trademark, and label your specific thing. In my mind, it looks like a fancy butter knife, but apparently the instrument is unique and curved and modulated and, incredibly obscenely expensive. I actually had a colleague do a presentation on that. And here's the very brief summary. Patients love it. And it's a very specific type of patient. It's a patient that needs, I saw this Thai masseuse and he was walking on me and I just need deep pressure. It's usually the lifter that wants to lift through their pain. Like, I don't give a crap about my pain. I just want to get my PR up, They're more into that I need to break things down type of mentality to build things up. Whether it be placebo, whatever not, it's hard to test a placebo on that type of intervention. But anecdotally, people really respond well to it. I don't use it. I get people better without it and with more, activity modification and motor control strengthening techniques. I know clinicians that use it. I have them try it and I say, listen, they're probably better at doing it. They probably know more about it. If you want that approach, I don't spend that much time with people on it, but I'm open to it, but the evidence isn't very convincing. It's just not great. So I look at what's the harm. And the harm to me is expectation for passive treatment. The notion that I can just keep beating myself up at the gym and then I can pay this guy $70, cash to, beat that out of me. I don't work well with that type of client and I'm very upfront with them. I don't give you a Tylenol so you can bang your head against the wall, so to speak. But I get it if that's, your thing, but I just don't feel like it's justified based on the evidence. But I am definitely open to it. I just can't get the logic behind it. Like
Yeah,
no
I
one
guess.
can explain to me what's happening.
Yeah, that's my question is, I mean, what is the mechanism besides the very obvious kind of acute petechiae you get from bursting capillaries and things like that? Like what is it doing at like a tissue level besides just, very superficial capillary damage?
I could go into some, fancy sounding word salad, but the reality is I have no idea. And I've asked that question repeatedly and I can't get a good answer. Oh, we're getting erythema to the, it's like all these fancy, it's like, no, what are we morphologically changing the tissue? And if so, how does compressing it, it's like trying to, massage a table by pushing through steak, that's on top of the table. Like, how are we penetrating tissue that deep? How are we reorganizing it? How permanent is that tissue reorganization if that's actually happening? How do we know how much pressure to put on, how much pressure, how much time would it take, how much force? These are things that I haven't got a great explanation for, which is making it even harder for me to implement in my arsenal of things I do.
Sweet. So if you enjoy the pain, you can do it, but it's probably not actually helping you.
Yeah.
Okay.
Yeah. One possible side effect, again, is it's distracting you from the real issue.
Yeah.
It's giving the illusion that you're treating something, but you actually might be barking up the wrong tree. If you're using that as part of an adjunct and you're keeping it in perspective that it might not be helping, it might help, but some people get very all or nothing, like, well, I'm going to try acupuncture. If that doesn't work, I'm going to try Graston. If that doesn't work, I'm going to try core stabilization. It's like, no, that's not how it works. But if you're like, I'm going to add this on as an adjunct, I wouldn't discourage you.
Yeah, and I wonder if that's a big part of it, because I know, like, in my basketball career, I've had, where like my IT bands have hurt pretty bad, or my patellar tendons hurt pretty bad, and whenever I had to play, I would always like foam roll or like use one of those tiger sticks like on the areas that hurt before I would play, and they wouldn't hurt as bad. And it may have been like some just acute desensitization. It never really like solved the long-term problem, but it was like, okay, at least it won't hurt as bad for the next hour while I'm running around.
Right.
Yeah.
Yeah, that makes a lot of sense.
So next one is dry needling / I guess we can throw acupuncture in there too. Thoughts on that?
Well, first of all, have you had dry needling performed on you before?
I have had one needle put in me once because I was a test person for when an acupuncture came in, and I volunteered he could put a needle in me, but I've never like gone to do actual therapy.
Yeah. There's a clinician that, was reaching out to me, and I heard about someone's where I'm like, before I start recommending same people to you, like, I'd love to come and try it. And it was a very interesting feeling. It's just, if you know anyone that's willing to use you as a pincushion, it's definitely cool to check out. There's a big distinction from dry needling and acupuncture. Acupuncture is more based on a philosophy of following so-called meridians, and has much more of a very broad and a non-mechanical explanation as to how it's helping. Dry needling, and this is a very rough overview, somebody who specializes in this is better at giving more specifics, is more mechanical. It's more trying to work on areas that they call trigger points, or areas that need to have direct stimulation. They're not trying to hit meridians. They're literally trying to target what most people casually call knots as trigger points. The mechanism seems to be a little bit more grounded in plausible physiology, where they're trying to cause either a fasciculation, which is like a mini contracture. There might cause some micro damage. Perhaps it's improving blood flow. Maybe it's reducing the hypertonicity of the muscle so it will relax. Either way, anecdotally, again, some people absolutely swear by it. I've tried everything to get rid of these knots in my shoulder. Nothing worked. I did a trigger point, and that felt better. So I've heard cases of that. Again, the evidence isn't great. The quality of the research is really poor. And that's one of the biggest problems. There's a lot of high risk of bias. Interesting related to that on acupuncture. There was a lot of studies in acupuncture and pain, and many of them have shown a positive effect of acupuncture. When they tried to do a sham study, and you know how much I like sham studies, I bring those up a lot. They found that the sham group did just as well as the acupuncture group. So in the sham idea, they're not trying to go in any specific meridian according to the like, I guess you'd call it the Chinese, philosophy of acupuncture. They were just randomly putting it there, and those people had relief. So it's starting to get people to speculate that it might be more of a neurophysiological mechanism as opposed to specifically a meridian. I know many very well-respected clinicians that have had good results with it. Those clinicians will tell their patients who have I referred to them, I don't know exactly how it works, and I don't know if it's going to work, and I'm not exactly sure why it works, but for some people it has a good effect. I think that is a very honest appraisal, and I think if it's also done with the idea that it is not a one-stop treatment. Nobody has ever, any responsible clinician I've known has ever said acupuncture will fix your problem. Mm-hmm. It's designed to be a adjunct to reducing symptoms, not to fixing any specific cause or blockage. So I think that's the most honest appraisal I can give you of that, and that's from clinicians that do that for a living exclusively.
Yeah, it's interesting. I have a few colleagues of mine that I respect very highly, just as thinkers, essentially, and they use acupuncture in their practice. And one of the discussions I've always had with them, and they're pretty open about it, is how much of the benefit you see is just from the whole theater of it, right? Mm-hmm. Just the full experience of you lay on a table, you kind of relax a little bit, you have all of these other things going on, and they also think that's probably a part of it as well. It's just kind of like a therapeutic session of something that's a little more passive, a little more relaxing, that kind of stuff. Yeah,
I mean, that is something that I tend to find myself a very unesthetically sensitive person. I could be in a woodshed and be fine doing my work there. I don't need pretty creative, nice, environments. But most people are, and even as somebody who is relatively insensitive to that, I can't find a practitioner in acupuncture who doesn't have a very inviting environment. There's a nice, not necessarily mystique, but just a very caring and a very aware surroundings around it. And I think just exposure to that and being somebody where there's nothing expected of you except for just relax and get treatment. I think that's a big part, and I don't think it should be thought of as foo-foo or not important. That being said, in the environment where I work, I can't reproduce that, and I don't even pretend to. So that's why I think it's good to have separate clinicians that just focus on that. But the big thing I try to emphasize, and I know all the ones I work with, is that don't think that I'm going to try surgery, or I'm going to try acupuncture, or I'm going to try massage, or I'm going to try acupuncture, or I'm going to do, physical therapy or acupuncture. Don't try to put things in separate silos to think that that's going to be an effect. Usually people are disappointed when they try that approach.
Yeah, I kind of think about them all together. So the next one we have is traction. And we talked a little bit about that earlier with Hannah's question. But essentially, how effective do you find traction?
Very effective. As long as it's intermittent and it's either self or manual. So the distinctions here are really important. What most people think of traction is that they lay on a table and there's a device that pulls on their head or pulls on their pelvis to, and there's ridiculous explanations that it's going to elongate your spine. It's going to, decompress, this, it's going to, lengthen all these tissues and stuff. Fortunately, we don't have good evidence that that's the case. If it were the case, we could do some really bad things to people. So, but what That's the mechanism or the environment you'll typically see that. It's a machine that tends to do it. The problem with that is that, one, the mechanism by which we think it works is when there's a pressure gradient that occurs, it helps facilitate passive diffusion and nutrient exchange. And that's particularly important at the spine where there's no blood supply to the disc. So there's actual evidence of better hydration and better nutrient flow to tissues after being intermittently loaded and deloaded. So there's a decent mechanism there. Just like any neural tissue, the minimization of a chronic stimuli, so the intermittent nature of it, that could be a variable as well. There could be a compressive component to it, but maybe not to the degree that it's taking pressure off the nerve, so to speak. Nonetheless, the clinical relevance of that is very significant. I literally have had scenarios where I've given people traction and tested and had another clinician testing their deep tendon reflexes and their myotomal strength, and it's acutely changed from the times in which they were under traction to when they weren't under traction. And you can often turn somebody's symptoms on or off with the presence or absence of traction. That's more acute cases, by the way. Somebody with 10 years of chronic back pain, it's very rare you're going to see that much of a difference. So intermittent nature is good because you can dose the amount of it as well. With your hands, you can very easily feel how much load to be or distraction to be applying. With a machine, it's very hard to grade that. Somebody's tolerance or ability to benefit from traction could be very minimal, or it could change over the course of treatment. It's hard to facilitate with the machine. The other thing, so intermittent and manual and positional. Traction may not work at all for somebody if they're in, too much extension of their spine, but it might give them complete relief if they're biased in deflection or vice versa. That's very hard to do with the mechanical forms of traction. So all those things can really drop somebody's symptoms down from like a 7 to a 3. And I do find that lasts, although it's relatively short. Maybe a day or two, they feel better, and then they're right back to where they came from. So the biggest thing I emphasize, what I was trying to talk with Hannah about, is that when you do have a positive response to traction, try to figure out how that can be done at home. There are home units, one called a Saunders unit that could do self-cervical traction and even some lumbar traction. There's some pretty creative ways that you can have devices, or even just using your own, body weight, that you can facilitate traction. So I have seen it work well. There is decent research on it. There's actually a classification system for spine care that identifies traction as one of the main components. Most often it's for people that have pain that radiates down into the leg or down into their arm, where we see the best effect from it. It's relatively short-lived, but if done frequently and you can do it on your own, you can have a really good strategy to control some of your symptoms.
So inversion tables, are you telling me I should get one?
Inversion tables are about a 50-50. You have to be relatively agile. It's, if you're a 70-year-old who hasn't exercised in a couple decades and you're stenotic and your therapist does traction and they're like, that feels great. There's a big difference between when your knees are bent and your hips are at 90 degrees and you're biased into a little bit of flexion, and somebody else is pulling you as you effortlessly get onto a table, versus being in full extension because your legs are straight and having to invert and dealing with massive fluctuations of blood pressure.
Yeah.
A young, healthy, agile person, and I hate to say young, a healthy, agile person, because you could be old and fit that description, and young and not, will find that, and they like neutral or extension. They will do great with that. Just don't hang out there for 10, 20 minutes. If you do it, get inverted at various degrees and then go back to neutral. Don't sustain it. There's at least theoretical evidence, but there's no proof of this happening, that if you undergo traction for prolonged periods of time, you can induce creep to the non-contractile tissues like the interspinous ligaments. And for many people, hypermobility is part of the problem. So you don't want to unwittingly get that as a consequence of prolonged stretch. So that's why the intermittent nature, plus you get the therapeutic effects of the intermittent loading, which can help facilitate nutrient exchange. So it's a long way of saying, if you meet those criterion, yes, inversion tables could be just fine. I can't believe how expensive they are too.
Yeah. No, it's pretty crazy. I've used one like twice because it was at a gym, and I just have, I can't be upside down for more than like 2 minutes. It's like, even when I was a kid, I couldn't like hang upside down on the monkey bars for too long, or I'd get like, I've never been able to do that. Okay, we have lasers.
Yeah, laser.
I can never say that without thinking of Austin Powers.
Yes, quit humping the laser. I know. I think of the same thing. The evidence is not great. It is pushed very hard because, again, passive modality meets patients' expectations for being passive. There's a lot of theater with that. The technology is alluring. If I have a serious problem, I have some unique technology, that rationalizes and justifies the unique nature of my problem. But simply looking at the evidence, it's not great. Okay. In fact, it's quite poor. Both the amount of evidence and the quality of the evidence. As you know, there can just be not enough evidence. But in this case, there's not a great amount of evidence, and the evidence that we do have isn't good. And again, I'm having a hard time wrapping my head around the theoretical mechanism behind it. But people make a lot of money selling those, and they can charge cash for them. And I know people love doing that, but yeah, I'm not a fan.
When I was doing one of my internships, I was at Gonzaga, and John Stockton would come in every day and work out, and he would always bring in this giant magnetic coil, and he swore by it. He was like, I used to use this every day in like the last 10 years of my career, and I'd put it on my knees, and it would help my knees. So he had this like giant magnet that he would just put around his leg and turn on every day. It was hilarious. It kind of reminds me of the lasers.
Yeah, well, Brett Favre's got those what are those copper infused knee sleeves. So
yep, it's pretty crazy. Yeah. Then we have ice and heat. Those are the last two.
Yeah, this is one of those things where if you like it, if it feels good, definitely do it. If you don't like it, doesn't feel good, don't worry about it. You're not going to hurt yourself. Well, I mean, you could technically hurt yourself. There have been some cases of people putting especially around the elbow and around the knee, if you're relatively thin, those nerves are relatively exposed, and you can cause some fibular nerve or some, ulnar collateral or ulnar nerve hypersensitivity with prolonged exposure. Like we're talking like, you have ice directly on your elbow for, a half hour. Some people have fallen asleep on hot packs, but barring those circumstances, it can help people a lot. Ice can really help people modulate pain for a relatively, low risk, low cost. That being said, a lot of people hate it. They're like, oh, I hate, I was like, well, it's not the end all be all. It's not like, well, you're just going to be riddled with inflammation, especially if we're talking about deep tissues like the back. I mean, there's no way in hell you're penetrating anywhere near the tissues. The deepest heat can maybe penetrate 6 centimeters. I mean, if you look anatomically at our spines, I mean, gosh, it's way, way deep, all that tissue that we're trying to influence. So I think it's mostly a sensory mechanism. When we're dealing with an acute injury like an ankle, there actually is a decent amount of debate recently about how much we should be icing ankles. I haven't seen any very convincing evidence, but the theory is that inflammation is actually good and can help facilitate acutely tissue healing. I don't see that as somebody who's had a big, giant, bulbous, huge, broken, swollen foot. nutrient exchange is impaired when you have extracellular fluid, really disrupting that balance of pressure, so you can't get adequate nutrient exchange. I think getting rid of that acute inflammation is not a bad idea, and I know ice helps with that. I do think, however, it's overused for tendon issues. It's overused for, chronic, quote unquote, tendinitis, which we know is tendinopathies now. So for pain modulation, use it if it works, if it helps. If it helps your back to relax, to get a hot shower on your back in the morning, you're doing no harm. It's perfectly fine. Definitely do it. Don't think that you're going to be writhing in pain if you don't have access to warm packs or cold packs. So probably overemphasize in its effectiveness. Definitely a good tool for pain modulation. And for acute swelling, I'm not convinced that it's not a good idea to do like the traditional recommendation is. So I definitely recommend in those circumstances.
Yeah, it's kind of like, it was maybe a couple of years ago where there was this big push to like nobody should ever take anti-inflammatories because taking them stops the inflammation process, which prevents you from like gaining muscle tissue. And there was a big kind of movement towards that. And the thought process is like, A, who's taking NSAIDs every single day, like post-workout? Right. And two, generally, like if you have to take them to solve an acute problem, like that's what they're there for.
Right.
It's just interesting that we kind of went the other way on like, hey, if you stop any inflammation, you're stopping the body from doing what it's doing. It's like, well, just because the body's doing something doesn't mean that's the best thing for the organism at that point.
Right, exactly. Nor is it, without it being controlled or, that's always a good thing. You brought up something about the NSAIDs. I think the bigger question is whether people have a reaction to them. They, perhaps as the only evidence I've seen of this is with long-term use, but that has been an issue with some people with cardiovascular problems. But an interesting thing to consider about NSAIDs on that inflammation thing, there has been some suspicion that it can delay bone healing post-fracture. So if there's been a suspected fracture or maybe like a growth plate injury, you're not sure if this is a tendon ligament strain, and you're like an 18-year-old baseball pitcher. You're wondering Tylenol versus, Advil or Aleve. You might want to gravitate towards looking at Tylenol if there's a suspicion of fracture. Not phenomenal evidence of it, but enough to warrant some concern.
Yeah, that's interesting. I guess that's kind of the argument of acute versus chronic use there of like, hey, if you need it for a couple of days to manage pain, probably not a problem, but I wouldn't take them for the 6-week bone healing period.
Right. Exactly.
Well, I think that wraps it up. We're kind of pushing our hour here. Any other last minute things you want to chat about before I let you go enjoy your nice New England day?
Yeah, just one thing to keep in mind is that there is some allure of these strategies, these techniques. Go back to the importance of how much is it distracting you from what you really need to be doing. Managing load, looking at what might be recreating or causing the problem. Spending time and effort on that will always pay off much more dividends than any new or recent advancement that we see in the effectiveness of those modalities. So, look at those as the small rocks, and, the modulating your training, your habits, your load patterns. Those are usually where you see the biggest improvements.
Yeah. Perfect. Awesome, Mike. Well, thanks so much for your time, and really appreciate having you here.
Yeah, it's great to be here as always, Brad. Thanks.
All right. Take care.
You too.